I fell in love with the physiology of it and just being able to affect change very quickly. We get to wear scrubs every day. We take people's pain away. We help deliver babies. We get involved in surgery. So I think an anesthesiologist really is that kind of full doctor that I think we all kind of wanted to be when we were growing up. My name is Alan Sim. I am the chair of anesthesiology here at Mount Sinai South Nassau. I'd say we probably do anywhere between 15,000 to 18,000 anesthetics a year.
My name is Nicole Ng. I am the Director of Perioperative Services. Perioperative services includes a lot more than just the operating room. After pre-surgical evaluation, the patients will be admitted into our ambulatory surgery unit. After ambulatory surgery unit, they are then taken into the surgical suite, the surgical arena, or the operating rooms. After the OR, our patients are then transferred to the PACU, which is where they're recovered from anesthesia.
My name is Travis Marbley. I've been with the Periop team and the Post Anesthesia Care Unit. So in a PACU, when a patient is waking up after having surgery, after having any type of anesthesia, IV sedation, general anesthesia, regional, they're transferred to the PACU. The PACU, our sole purpose is to, ensure the patient is stable, make sure the patient has a smooth recovery, waking up from the anesthesia.
So people don't really think about the PACU a lot because it's not revenue generating. You really don't have enough PACU space to accommodate 15 ORs, and if particular patients may need extra time, or maybe they are slated for admission, or they're slated for an ICU admission and there's no beds. So those patients are gonna stay in the PACU and you really only have limited space. So that was one area that was problematic. The other area that was problematic was that we had to have an anesthesiologist physically sign out the patient to make it to that next level of care.
When I first got here 3.5 years ago, we were hovering at about 200 minutes per patient for PACU length of stay. There were a multitude of different reasons for this, but Dr. Sim was able to collaborate very quickly with the Department of Nursing in identifying those inefficiencies. One of the inefficiencies that we realized very early on was that there were no computers anywhere for his physicians to put in orders, discharge orders, for patients that met criteria and were ready to leave PACU. The PACU nurses have the skill set and the criteria to discharge a patient from PACU as long as the patients met certain criteria. So he, in working conjunction with the Director of Perioperative Services and the PACU nurse manager, empowered the nurses. So it really kept the flow of PACU moving as well, and didn't put the onus on the doctor, but really empowered the nurses to make those decisions.
One of the other changes that Dr. Sim has made has been assigning anesthesiologists to the recovery room for direct coverage in case we need things. For example, we need orders, we need pain medication, there's an emergency. We always have somebody who's directly assigned to the recovery room, medicating patients in a more timely manner. We're not waiting for orders to be reviewed because they're already in.
And then the other thing we did was we opened up what was like a fast track PACU. So for patients that were undergoing lower acuity procedures, things that, are generally were short and didn't require a significant, fluid shift, we were able to send those patients directly to another space and completely bypass the PACU. So they would go from phase 1 recovery to phase 2 right away. And that also decompresses how many patients are gonna be in that PACU at a given time.
We can go straight from the OR to the fast track, and those patients are out of the hospital sooner, as opposed to having to recover for an hour. They can recover for like 30 minutes or so.
Before we made these changes, you were looking at probably about anywhere between 100 minutes to 120 minutes. So 2 hours in the recovery room. And I can say that we're well below 90. We're probably at about 70 or 80 minutes. And in terms of the endoscopy unit, it used to be about an hour in recovery, and now it's about half hour.
The patients are excited that, oh, I don't have to wait here a long time after surgery. I can actually go home. I see my family sooner.
You hear all across the nation that patients are sitting in the operating room waiting for beds, and that ultimately leads to, subsequent case delays surgeon frustration, patient frustrations. Now you have patients sitting in the holding area waiting for their surgeries. It grinds the hospitals to a screeching halt. But having the PACU length of stays go down so much, it makes sure that the operating rooms stay humming and moving and increases throughput and efficiency throughout the whole organization.
We called it the Perioperative Improvement Project. And so it really was to make sure that we could decrease turnover times, make sure that we can get more cases done in the amount of time that we have our resources. And again, I think that leads to a lot of satisfaction on all of our parts.
One of the biggest changes, since Dr. Sim has come on board and Dr. Coleman working with him, has just been the level of efficiency with the throughput process. That's just something I can't emphasize enough. And us working together has created such a streamlined process here in the recovery room that it's never been more efficient than now.
Having a team like NAPA here, they're all so well trained, having a chair that really implants himself into the culture and into all the administrative meetings here throughout the organization is so vital. Oftentimes people don't realize how many areas and how many facets that anesthesia does affect throughout the hospital. If you don't have anesthesia services, you don't have a hospital.